जरा ते लॅप्रोस्कोपिक गॉल ब्लॅडर करायचं म्हणजे मॅडम जरा टेन्शनच असायचं.
हो, पण
पेशंट
तू
मॅडम
सगळे
पहिल्याच दिवशी नाही का,
सगळेच फायनल मध्ये केले, मी
मी
एकही
सगळेच
फायनल
फायनल मध्ये केले मॅडम. माझं नाही का 2-3 केसेस झाल्यानंतर माझी एसओपी सारखं असं तयार झालं होतं की हे स्पायनल द्यायचं. प्री मेडिकेशन मध्ये ॲट्रोपिन मी देत होते मॅडम, म्हणजे बीपी वगैरे बघून. आणि केटामिन एक ठेवलं होतं स्पायनल दिल्यानंतर, इफेक्ट आल्यानंतर शोल्डर टिप पेनसाठी 30 मिलीग्रॅम.
Karne sir is traveling and is joined, I think.
मॅडम लॅप्रोस्कोपी स्पायनल खाली गॉल ब्लॅडर मी कित्येक केलेत, म्हणजे 2003 पासून अजून करतोय. हिस्टेक्टॉमी चालू आहे, आता पण लॅप्रोस्कोपी चालू आहे माझी. स्पायनल खालीच आहे, चालू आहे ते केस. पण केटामिन वगैरे मी सिडेशन कधीच देत नाही लॅप्रोस्कोपीला स्पायनल खाली.
शोल्डर सर
शोल्डर
सिडेशन
पेन,
नाही, शोल्डर टिप पेनला सर मी 30
शोल्डर पेन
मिलीग्रॅम आहे
तेच
ना.
सांगतो मॅडम. शोल्डर पेन
हा.
साठी ना मी डायफ्रामॅटिक इन्स्टॉलेशन ऑफ
अच्छा, तुम्ही सेन्सॉर
झाले.
कॅन इन्फिल्ट्रेट करता.
त्या
अच्छा.
दोन्ही साईडनी 2 सिरिंजनी किंवा
हो हो.
आपले जे त्यांच्या स्कोप मधनं डायरेक्ट दोन्हीकडे टाकलं ना,
हा.
10 सीसी हे अॅनाविन आणि 10 सीसी आपला लॉक्स, हे दोन्ही
अच्छा.
जर एकत्र करून दोन्हीकडे इन्फिल्ट्रेशन करतो, इन्स्टॉलेशन करतो. इन्फिल्ट्रेशन पण नाही म्हणत
अच्छा
त्याला,
अच्छा.
इन्स्टॉलेशन म्हणतो आपण.
अच्छा अच्छा.
इन्स्टिलेशन केलं ना डायफ्राम कडे
हम्म.
की काही प्रश्न येत नाही.
अच्छा.
पण शेवटी माहितीये का, काही जरी झालं ना तर
सर
सगळ्यात कम्फर्टेबल हे इंट्युबेशन केल्यावरच आहे.
तेव्हा पल्स पण नव्हतं ना.
हा, इंट्युबेशन हेच खरं म्हणजे
सर तिथे काही नव्हतं, सेन्सॉर केन नाही, लिग्नोकेन
हम्म.
नाही सर तिथे. तिथे ड्रग्स नॉरॅड वगैरे शोधून कसं तरी, नाही तर ॲड्रिनालिन काढून ठेवलं होतं. नशीब लकीली एक कुठेतरी मला नेझल एअरवे सापडला आणि मी खूप कम्फर्टेबल आहे नेझल एअरवे सोबत. तर तो नेझल एअरवे बघितल्यानंतर मग माझ्या जीवात जीव आला. म्हटलं आता काही घाबरायचं नाही, म्हणजे
मॅडम आम्ही
नाही
जाताना
इंट्युबेट.
आम्ही
पेन पण
जाताना आम्ही
नव्हतं सर, साधू.
आमचे स्कोप आणि LMA एअरवे बुजी डिफिकल्ट इंट्युबेशनचं सगळं घेऊन गेलो होतो, आणि ड्रग
सर
सुद्धा.
आम्ही काहीच नव्हतं नेलं सर. कारण नाही का जलबाजी वगैरे त्यांनी आहे ना, त्याचं काही लॅप्रोस्कोपीचं सामान घेतलं तर सर एअरपोर्टला त्यांना पकडलं होतं, म्हणजे की नाही नेऊ शकत म्हणून. कारण काश्मीरमध्ये काही पण आपण घेऊन जायचं इन्स्ट्रुमेंट्स वगैरे, तर ते अवघड होतं सर. ते सगळं आपल्याला डॉक्युमेंट
नाही
करावं
नाही नाही,
लागत
ते
होतं.
तुमच्या लगेज मध्ये जातं. आमच्या इथं पण सर्जननी त्यांच्या सीझर विझर वगैरे पण आणले होते ना, त्या काढल्या होत्या
हा
ना. लगेज मध्ये
हा
नाही काय प्रॉब्लेम येत. लगेज
हा.
मध्ये
पण
टाकलं
मग
तर काय नाही, तुम्ही कॅरी करता येत नाही तुम्हाला,
अच्छा.
हँडबॅग मध्ये नाही ठेवता येत.
हम्म.
प्रधान मॅडमच्या चुकून राहिल्या सीझर्स त्यांच्या ऑप्थॅल्मच्या,
हो.
आणि सीझर
तो
त्यांच्या इतक्या छान फाईन सीझर
हा.
त्यांना टाकून द्याव्या लागल्या. इतकं वाईट वाटलं
हो
जम्मू
हो हो
एअरपोर्ट
आपण
वरती.
सुरू करूया का आता?
हो, सुरू करा मॅडम. ऑलरेडी
करूया ना सुरू? हा.
चला.
ओके.
Uma madam, good evening. Avinash sir,
Okay.
good evening.
Good evening all. Very, very warm welcome from SAPC to everyone. It is my great pleasure to begin this webinar today.
ओके करके ब्लैक लाइन हट जाएगी.
All of us are proud Indian citizens and love our country very deeply. There is a lot of international traveling happening these days. Most of us have roamed around the developed countries. We sense the difference. But despite all the problems and shortcomings we face, we hear that it feels comfortable in our own country. Now let us think about it. What makes us feel comfortable in our own country? And who looks after that safety? Is the armed forces of our nation. We feel safe because the armed forces of our nation is looking after our safety. And who looks after their health and safety is our army doctors. They are the ones who use their skills with incredible courage and integrity at the hardest places on the earth. So, friends and colleagues, I proudly welcome two army doctors today, Lieutenant Colonel Dr. P.S. Garcha and Major General Dr. Rashmi Datta. A very, very warm welcome to you both. Dr. Rashmi Datta has earned the Vishishta Seva Medal. Very warm welcome from SAPC to Sir and Madam, both of you. Also, we welcome our own Dr. Neha Panse, Secretary of Pune Anaesthesia Society, who has recently accepted to be the head of the Department of D.Y. Patil Medical School, Ambi Talegaon. Friends, we have a proverb in Sanskrit. It says, Yuddhasya katha ramyaha. It means listening to war stories is entertaining and thrilling as we are cocooned in the safety of our cozy homes. But for those who are out there, it can be horrifying and devastating. Our knowledge about war heroes, lives of soldiers, their families, all comes from Bollywood and Hollywood movies which we watch, and a handful of books that we read. All else is our own imagination. So, can you hear me?
Yes, ma'am.
Yes, madam, yes.
Yes.
Yes, we all can hear you, ma'am. Yes.
Yeah, I think the screen, something went wrong with the screen. So that initiated the thought of arranging this webinar. Let us look at the reality in face. So, without wasting my time, I will introduce today's chairperson, Dr. Lieutenant Colonel P.S. Garcha, sir. He graduated in 1970 from the Armed Forces Medical College, Pune. He did his DA in 1978 and MD in 1980, both from University of Pune. He served in Army Medical Corps in various capacities from 1971 to 2000. As a young medical officer, he served in the Western Sector during 1971 Indo-Pakistan War. He took premature retirement from services and he served as professor in the Department of Anesthesiology, AFMC, Pune. He served as a senior consultant and head of Department of Anesthesiology at Sancheti Institute of Orthopedics and Rehabilitation Center for 8 years. He was a senior consultant and head of department at Aditya Birla Memorial Hospital for 9 years. He has many achievements. Awarded Chief of Army Staff Commendation for exceptional devotion to duty in 1986. He got a Best Officer Trophy for standing first in Medical Officers Senior Command course. He is trained paratrooper, trained in simulation anesthesia at University of Auckland, New Zealand. Adding to his achievements, he has also served many academic bodies in various capacities. He was a treasurer of RSACP, secretary ISA Pune City branch, and he has 30 publications to his credit, both national and international. At present, he is director of medical services at the prestigious Sancheti Hospital, Pune. I request sir to introduce our first speaker and start the webinar.
Thank you, ma'am, for those words that you have spoken. And just before I introduce our first panelist, our first speaker, I would just like to tell you that time permitting at the end, I shall give you a small 3-4 minutes talk on the Indo-Pak conflict. That was not as an anesthetist, because that was the initial phase of my service. And I was an MO that time with only 10 months of completed internship. We were shunted out from Command Hospital, Lucknow that time. So if time permits, at the end.
So definitely.
Ma'am Neha Panse is now professor and HOD Department of Anesthesia at D.Y. Patil University School of Medicine at Ambi Talegaon in Pune. And I believe she's been there only for a short while. Before she was, I think, in Navle, if I'm not wrong.
Yes, sir.
Yeah, and she has 14 years of teaching experience, has over 20 publications to her credit, has been awarded for paper presentation at the National ISA conference. And she shall be speaking on Healing Beyond Hills, the Kashmir Surgical Camp, which was, I believe, was held at Kishtwar. So I request Dr. Neha Panse to begin her presentation, please.
Thank you, sir, for the kind introduction. At the offset, I would like to thank SAPC Anesthesia Society, Dr. Uma Deshmukh ma'am, Dr. Chaya ma'am, for giving me this opportunity and considering me to be eligible for this platform. I feel great and obliged to present my experience in front of all of you seniors. Some of might have already gone through this experience, but for me, it was really delightful and thrilling. Screen is visible.
The larger picture has disappeared. Yeah, now it is. Yes.
The full, I think is it visible all right?
We can see the Kashmir surgical camp in the center.
Yes. Is it?
Pres-
So we began this camp through the Rotary Club of Pune West, as I am a member of the Rotary Club of Pune West. Through that, I got introduced to this opportunity and we started this. This was scheduled on from 17th of April 2025 to 24th of April 2025. This was the banner, and under this banner, we had plenty of registrations which had started around 6 months ago in preparation of this project. Volunteer doctors from all over the Maharashtra were invited and joined to serve in the remote districts of Doda, Kishtwar, and Bhadarwa. Doda, it has a medical college, while Kishtwar is a district hospital, whereas Bhadarwa is a sub-district hospital. So you can imagine the facilities and conditions in these areas. We started our journey from Mumbai to Jammu through flight, and from Jammu we were carried to the respective stations. This is our team. We had a very grand welcome in the Jammu Rotary Club office. The lady in the pink is, I should mention, she is the Queen of Jammu, and she herself was present to welcome our Rotary team. We were glad that she came and received us. This is our bus. Everywhere there were banners all over the roads and territories that this camp is being organized, and the people were thrilled that कब हम जाके एक बार ऑपरेशन करा लेते हैं, पता नहीं डॉक्टर्स फिर कब आएंगे. The entire team of 18 members, we were 4 of us anesthesiologists, Dr. Shyam Kulkarni from Loni, Dr. Karuna Patil from Nanded, Dr. Manjusha Bhume from Chhatrapati Sambhajinagar, and myself from Pune. I'm sorry to say, but Dr. Shyam sir is no more with us. He passed away 2 months ago. We were 2 teams. We were divided into stations. Like Doda, the anesthetist was not provided. As I mentioned, it was a medical college. So we take it granted that there was a anesthetist. In Bhadarwa and Kishtwar being the suboptimal stations, we were divided into 2 teams. Dr. Karuna Patil and myself were posted in Bhadarwa, and Dr. Shyam Kulkarni along with Dr. Manjusha went to Kishtwar. On 18th of April, we started actually for the surgical camp. A huge inauguration function was conducted at the Kishtwar District Hospital by Lieutenant Governor of Jammu, Mr. Manoj Sinha. This inauguration was physical, while rest at Doda and Bhadarwa, it was an online inauguration. Heavy security check was there, and even we were checked for 4 times, and we were not allowed to enter the hospital before confirming our identity and the whole thing. The first case posted was a hysterectomy. We were ready, myself and Dr. Karuna were ready to do the case, but the gynecologist said, "Ma'am, अपने को blood नहीं मिलेगा यहाँ पे, तो मैं तो नहीं करूँगी." If the surgeon is not ready to do the case, what could have we done? We definitely left the patient, counseled her, and referred her somewhere. Then we started the first case at 12 p.m., which was laparoscopic cholecystectomy. This was being operated by Dr. Girish Gune. He's a famous laparoscopic surgeon from Thane. And to the surprise, his assistant was an orthopedic surgeon, because we didn't have assistants there. Staff was not sufficient. To our surprise, the laparoscopic instruments were really amazing. They were so sturdy and so stout, they were not ready to enter the rectus and the peritoneum. And we were struggling, Dr. Gune was struggling for puncturing the peritoneum and enter the cavity. But no worries, with somehow we managed to do the case. After 3 hours of struggle, we could complete the case, and we thought we had to complete the list. So we thought of taking another OT parallelly, as we do always. But to our surprise, they had only 1 cautery, only 1 suction machine, and only an assistant who was closing in the first theater. So who would assist in the second theater? Dr. Gune was alone. Somebody was needed to hold the instruments. So myself held the instruments along with Dr. Gune, and Dr. Karuna Patil was waiting in the first theater to let the patient get extubated. This is our first patient, and you can see Dr. Gune is struggling to do the case, and the resident is busy preparing some drugs behind us. This was the sub-district hospital of Bhadrava. 3 laparoscopic cystectomies we could do from 12 p.m. to 7 p.m. because of the instruments were not proper. So we had to struggle a lot. One single surgery took a lot of time. So it was a difficult first day. And cherry on top of that was the recovery area was unmonitored. So myself and Dr. Karuna had to come back late at night to check the patient status. In Kashmir, coming at 10 p.m. in night is really scary. And when we came back, Dr. Karuna's room, the geyser blasted. So one room was out of order. So 4 of us had to adjust in one room, which was after a tiresome day. It was really difficult to go through all these things in an unknown place. The second day, I had the transfer order because in Kishtwar, the number of cases were more. So I had to pack my bags and travel from Bhadarwah to Kishtwar. It was around 90 kilometers, 6 hours travel by car in a hilly terrain. It was really tiring the next day, immediately after so much of travel, first day. This was our guest house in Bhadarwah. And back there, Karuna ma'am was left alone managing all the cases under GA. Literally, she had no help from anesthesia side, and managing cases in the setup of Bhadarwah was really difficult. Ma'am successfully did it for continuously 6 days. Great, ma'am. In Kishtwar, I met the new team. There were many cases, but the resources were limited. OT tables were not sufficient because we had to run 3 to 4 tables simultaneously because the list was too big to finish in 4 days itself. What was done? Mortuary table was converted into an OT table, and the light was not there. So 15 amperes LED light was attached to the holder bulb, and under that the hysterectomies were done by Dr. Anil Sakre, the gynecologist. He's a great surgeon, I must accept it. The OT was all ready with this jugaad. Challenges we faced were during PSC, the language was a big barrier. The people there were not at all cooperative. We requested them, can please somebody do the PSC for us, because there was an anesthetist posted there, but he denied that I'll do my own cases. I'll not help you in PSC. There were multiple cases. Myself and Dr. Manjusha somehow managed to do the PSC along with the RMOs. And we had difficulties because the patients there are also obese. Actually, the OT table was not sufficient for some of the patients. With great difficulties and arrangements, we could manage these patients. And we had no other option other than regional. GA was not at all considerable in such situations. In one condition, I must tell that we had an obese patient for hysterectomy, vaginal hysterectomy. Obesity was a big problem because accessibility of the organs was difficult for Dr. Sakre. And under such light and table conditions, the patient started bleeding. Patient was obese. Dr. Manjusha was doing alone in that case. I was doing for laparoscopic cholecystectomy. She called for help. Then we had to run for another IV access, which was difficult. People there did not have any other, they did not know where to help and where to start the help from. So in a way, I felt that good that I was transferred from Bhadarwah to Kishtwar. That was a great thing. Blood products were difficult to reach, but somehow with colloids, we could manage that patient and she recovered well. Cataract cases were plenty and empty in number. There were around 25 to 30 cases. These all elderly males and females. They just thought this is the only one opportunity in their life where they can get operated for cataract. Next time they may or may not get the opportunity. They were not sure. So they were running like anything, like, please, hamara kar do, hamara kar do. And we did it. Dr. Sham Kulkarni was our block expert. He single-handedly young 80-year-old young man managed single-handedly all the opthal cases. Outside the theater, he used to give block for the patients. Patients were taken into the OT, and he used to keep ready the next patient. Amazing person he was. We did pediatric orthopedic cases also. These children were, they had long-standing deformities which were neglected. As you can see in the picture, this patient has a varus deformity, bilateral legs. And arranging the circuits, tubes, and managing the pediatric anesthesia was really difficult for us, because we only two of us were there, and we had to manage simultaneously gynecology and surgical theaters also. Red rubber tube which we used because no other tube was available. As I learned, studied in MD, I had never used the red rubber tube. It was only a museum thing. But in Kashmir, I had to use it. And I mean, it was a savior in the time of crisis. This is our team. On 20th and 21st of April, we had run simultaneously 4 theaters: general surgery, pediatric orthopedics, gynecology, and ophthalmology. Sham sir was single-handedly managing ophthalmology, while myself and Manjusha ma'am were running here and there, managing the theater simultaneously. This is the gynecology theater. As you can see, no visibility. This doctor is standing on the stool and visualizing if something can be seen. The conditions are really difficult. These are some of the pictures. This is the deformity of that child which we had corrected. This is our orthopedic surgeon. This is the bilateral varus deformity. And some of the glimpses of the cases. Now, only work will not serve. So we had some extra this was excursion time also. The local people who held us in the camp said, we'll get to see you this power plant of Dulasti. In Kashmir area, such a big hydroelectric power plant is not accessible to a common man. Like if we would go for a trip, like with family trip, we would definitely not be able to visit inside this power plant. But I must accept the enormity of the natural resources our Mother India has, and we should definitely protect them. It is very, very important and beautiful. This is the Dulasti power station, and these are you cannot imagine without seeing what is the depth and weight of this power station and the machinery which is built into it. It is really amazing. This is our team who took us to the power station with all the permissions and necessary government formalities which need to be done before going to the station. One of the patients who was operated on the first day of the camp had called us just to have a small cup of tea at her place. And the warmth which we faced at her place was, I mean, it is really unexplainable. We cannot express in words. She is the patient with the green scarf. She is the patient. She was on day 5, I think post-op day 5. This patient was talking and doing her daily activities. She had recovered so well. In Kashmir, they ask us to sit on the floor. The floor is full of these thick blankets below also, and you just slide into these blankets, and it is amazing. And what a cozy experience it was indeed. It's a single room it was, but the warmth was unbeatable. And for snacks, they give you these boiled eggs and omelets, because the chilling temperatures, these only can provide you the enough warmth which you need. Then the gynecology department of the district hospital of Kishtwar bid us at the goodbye party. They had called us for the dinner at one of the staff doctor's home, and really it was an amazing experience. The food, the gestures, their houses, I mean, whatnot, everything is so different and so warm that it is really one of the experiences in life. Really blissful it is. These are our new little cute friends. These are the kids of the caretaker whom were in the Dak Bangla where we stayed. Okay, these girls were, I mean, just They are just adorable. We gave them the pizza party and they were so happy the last day before we left. And no anesthesia sessions are complete without goals. Myself and Dr. Manjusha, along with Dr. Shamsa, we conducted the polls activity for the nursing students and the assistant staff of the district hospital of Kishtwar. Around 100 to 150 students were available, and they were surprised to know the technique, which is simple and can easily save the life. They said we were taught some other way, which they couldn't practice it. But now they will practice the right way. That was a great thing for us. The last day of it was routine morning, routine post-op rounds. We went to see up the patients. We winded up by 2:30 and we were about to go for the post-op rounds with the DM, and the press conference was planned at 4 p.m. in the evening. And the news flashed, the Pahalgam attack. We thought that it is just a rumor. In Kashmir, this is common. It comes and goes and people are also used to it. But later on, it really was a true news and we were actually scared about it. The camp ended with the district collector's round and a press conference where he praised our work and promised to do more such camps and support us. These are the pictures. This is the district collector of Kishtwar, Dr. Manjusha, along with Dr. DM, taking the rounds of the patients. This is Dr. Sham Kulkarni. The surgical camp was widely praised and covered by a lot of news channels and newspapers. This is our team, really supportive. And the people of Rotary, other than medicos, also took care of all the logistics which were needed and many other things which we asked, and they made sure that they provided it to us. So it was a really great experience. But this Pahalgam attack news turned out to be true, and we were asked. Actually, we were supposed to leave at 7 a.m. in the morning for Jammu, and our felicitation program was planned in Jammu. But we were evacuated in the dark of 3:30 p.m. a.m. 3:30 a.m. And then we saw that we could reach the safe zone before the sunrise. Once we crossed that limit of the safe zone, we took a breath of sigh, and then we could relax. It was complete darkness, complete silence. They said talk only in Marathi. Don't talk anything to anybody. If you want to talk anything, talk softly. Talk only in Marathi. No lights were allowed after 8 p.m. And then in the night, our vehicles were full security and both ahead and behind. This is my team. Lovely friends I made there. Wonderful experience it was. In OT also, being such a stressful condition, we enjoyed a lot. Dr. Sham sir, we'll miss you. Total 278 cases were done in 7 days at 3 different stations. And it was a great experience in it. These are the security everywhere. We could see security. This is my entire team. This is the Raj Bhavan, and we were felicitated. We were supposed to be felicitated on a larger platform, but because of this Pahalgam attack and the curfew, we were felicitated in a. This was the newspaper covers the entire news for a long time. Thank you. It was a wonderful experience, and a lot I could learn from Dr. Sham sir, Dr. Ma'am, and Dr. Manjusha ma'am. Thank you all.
Yeah, thank you, madam. Can you hear me?
Yes, sir.
Thank you, madam. Lovely talk. And the experience that you had will be shared by so many people and liked by so many people, but you yourself will be carrying it for a lifetime. That is one thing. And you must have experienced resource crunch, trained manpower, but the warmth of people there in J&K must have definitely compensated for everything that you got in the initial phase. So great talk. And
Thank you, sir.
and we'll have the next speaker, Madam Rashmi Datta. General Rashmi Datta, I know her for for over 25 years. She is a great soldier, highly decorated, erudite, and very eloquent in her talk. And she's MD Anesthesia, DNB General Medicine, DNB Aviation Medicine, and she's recently acquired fellowship in emergency medicine as well. Um, Currently, she's working as professor and director ICU in Adesh Medical College and Hospital at Ambala, which is in Haryana, very near Chandigarh. Highly decorated officer she has been during her 4 decades of service in the armed forces. She is VSM, that is Vishish Seva Medal. She's also decorated twice by the Chief of Army Staff Commendation. We have a 2-level commendation. One is at the Chief of Army Staff. She's had twice in her tenure, in her service tenure, and twice the Western Command, Southern Command, and Western Command commendations. So in all, she has got 2 plus 2 plus 1, 5. If I missed any, ma'am, please do. So five decorations, highly decorated. Her contribution to the specialty has been immense over these years. To name a few, she is involved as a member in national guidelines on organ donor management. She has also formulated the Indian guidelines on CPR. She has also authored 3 books on anesthesiology. Several chapters she has contributed in journals and in books. She has published more than 70 papers in national and international journals. She's also been a PG examiner for several universities, and she's mentored PG students throughout for the last, I think, more than 25 years. And she's represented India in a Cobra Gold International Disaster Management Exercise with Indo-Pacific Command of USA, which involved 12 other countries of the world. So that was a great achievement that Madam has to her credit. She's also participated in Op Sadbhavna, Operation Rhino, Operation Rakshak, and Operation Parakram during her 4 decades of service in the armed forces. She also holds a rare honor of being the first lady general officer in the specialty of anesthesiology. Here, I think she deserves a clap for this wonderful achievement. So I would now request her, and our topic of discussion today is anesthesia in the armed conflict. So I think she'll be touching upon armed conflict, where active, what Madam Neha has done beautifully is during peacetime. And I think she may talk on certain aspects during war. So Madam Rashmi Datta, please.
Thank you, sir. Am I audible?
Absolutely, yes.
Yeah. Thank you, sir, for such kind words. It has always been a great pleasure meeting you and interacting with you. Like you said, we know each other from almost about 30 years.
Yes.
You have been a person who has been responsible for inducing so many patients, students into our specialty. So that one achievement of yours is, has been handed down word to mouth. I would also like to thank Dr. Uma for giving me this opportunity to speak on this topic. I'm taking this opportunity to talk about, the anesthesia in armed conflicts, because what we saw just now in Sindhur, that we had to get people from, if I may use the word civilians, to supplement the military requirements at times. At least in Punjab and Haryana, we did do that. So based on this and just a general information as to what is happening with the armed forces. Now, when you have a surgical response in an armed conflict, there's a humanitarian response also there. It poses quite a few challenges. The security requirement is there, which Dr. Neha has mentioned, and constraints of resources. The limited deployable surgical assets, they're not not available. She mentioned red rubber tube. Both Colonel Garcha and me smiled
Yes.
because we've actually used them,
Use, yes,
on real
absolutely.
patients.
Yes.
And then we talk about mass casualty events, which can overwhelm the local medical resources. Now you have to need to address the, traumatic and the non-injury related emergencies, both of the population. Now, coming with this, I'm talking about the wartime. We've always learned from war. This is sad, but it is true. A review of the Vietnam War casualties took place in late 1990s and late 80s. And then they decided that a paradigm shift took place in the type of war management or what happened in mass casualties. Between 93 and 96, what all they got from the Vietnam War, they undertook a combined effort of the US Navy SEALs and other special operation medicos, and they tried to put it there. It was, give it a test run. And 1996, the first publications of the tactical combat trauma, their care was the guidelines by the US was published, and 2001 onwards, it has been transitioned to the service. Now, the tactical mortality has remained almost unchanged for the first 6 minutes. That means that the instantaneous death remains almost same. Now, after 6 minutes, almost about 80% of the people will still be alive. Now, this 20% who die in the first 6 minutes is usually because of severe injuries to the body, torso, and the head. After that, because of other things, you have self-aid buddy, the ALS system, antibiotics, all these have come inside and gradually decrease the mortality down to roughly around 50%. Now, the question comes, why do we actually need tactical trauma care? This has been because most combat fatalities die before they even reach the care of a hospital. They die before the hospital reaches. And this was said in 1984 in a landmark publication. There are very serious wounds which take place in battlefield. If you can see this, earlier on, 5% now has become in Operation Enduring Freedom recently in Iran. And in Vietnam, comparing both the two, 5% for the head and the face and all that is now 10%. Head and neck from 4 has risen to 10. Then extremities from 28 to almost 58. Now, this I feel has been basically because of the protective covering which which the soldiers have been given, so that their chest, torso, and chest and abdomen are protected. But with better guns and firing and from the enemy action, the extremities and the head have been targeted. Now, at Kargil War, we talked about what has been, as Wikipedia has taken out, 526 dead and about 1,300 or so, 1,400 who were wounded. But by 2024, they said that almost about 16 or 1,700 people have lost their, I'm talking about the paramedical, have lost their lives in the armed forces in the conflict which is going on in the valley. However, now recently they have said it about 3,600 is the total approximate figure. It is quite significant, but for India. But if you look at it, this is not a full-fledged war. But if you look at what is happening just now in Ukraine, I'll come with the figures later, almost about 2 million they have talked about in Ukraine. So loss of life is enormous. Now, usually the standard of care which has been applied has always been based on civilian trauma management principles. We have already seen that. ATLS is from the American College of Surgeons. It's a civilian trauma management. The European Trauma Course, the ITLS, all these have been incorporated into the military. However, there is a fundamental difference. We have very unique patterns and types of wounds, and this makes it very difficult to determine which intervention to perform at what time. And the tactical conditions, even the medicos face during war. At the time of war, it is not just, being in solid buildings. It is also what you have to do in front when you're in the front line. It all started with the USC Stars, in which 100 busy civilian trauma academic medical centers, they were joined together and they formed a type of training for the US forces. This was amply ratified in the Operation Iraqi Freedom. Then came inputs from the joint theater trauma system and the registry which they managed to maintain. That is the documentation. In the end, I'll just show you a few slides about how they maintain this registry, the documentation, where everything can be later analyzed and more inputs can be taken from there. The the US Army Institute of Surgical Research, all these combined together made this Tactical Combat Casualty Care, TCCC. This was later approved by the civilians, the American College of Surgeons and the National Association of EMTs. Now, the aim of the TCCC was to avoid preventable deaths and to improve the combat trauma outcomes in tactical pre-hospital environments. Now, I just wanted to give you a brief thing as to what is happening around the world. Israel has got their own battlefield training, that is the Military Trauma Life Support Course, in which everybody takes part in this. Now, this has been partnered with the civilian institutes, famous ones like the Sheba Medical Center, and in which they give you clinical guidelines and simulation training. This is a multi-layered, Israel, small country, but a multi-layered approach they have given. First to MOs and paramedics, first responders for combat soldiers, the responding treatment. And then they're talking about remote damage control resuscitation, where freeze-dried plasma and other blood products in the pre-hospital setting can be sent directly ahead of the hospital with combat drones. So then UK has its own Battlefield Advanced Trauma Life. It uses the CABCD approach, unlike the current ATLS one. It uses C. C stands for catastrophic bleeding, and the standard ATLS carries on beyond that. Now, here this UK talks about the tactical constraints of point of wounding. That means wound which takes place at the point near the enemy action. And then they talk about incremental enhancement of intervention skills, diagnostic equipments, where they should be placed, what level they should be placed as one goes backward from the line of actual control. And they talk about experience-based judgment, and the trauma team should be more sophisticated as one gets back and back at the successive echelons of care. UK BATLS talks about 4 levels of training: care under fire, tactical field care, field resuscitation, and advanced resuscitation. Now, when we talk about a field hospital, it is something akin to what was happening, what Dr. Neha has just shown. That is the civilian setup we have in the armed forces. All over the world, we have them. That is known as a field hospital, where it is slightly austere conditions, but otherwise things are available there. Now, UK has stressed on sequential assessment. That means as the patient moves backward, every time to keep assessing them. Permissive hypotension and hemostatic resuscitation is very heavy on their thing. They are also talking about intermediate, and the importance of CT scans, which should be as close as possible to the front line, wherever they can get it. Now, UK also has a combat trauma life support for austere conditions, in which with their limited medical equipment, or you have prolonged evacuation time, you're stuck over there. Now, this has been faced quite recently in Ukraine. I'll just talk about this also, where it is not possible to move the patient backwards at all because of the ongoing war. Now, here they have also emphasized on the use of tranexamic acid and intraosseous access. Today's war. These are horrible pictures, quite familiar, which we have seen there in the war which is there, and the high intensity weapons which are being used now are causing enormous damage. UAVs and UCAVs are being used, unmanned aerial vehicles, which can cause damage and can strike and come anywhere. They are undetected, they fly under the radar. So this has changed in recent conflicts. Modern portable anti-tank guided missiles, it was there in certain parts of our country also by the people who are fighting against our country. These were available there, but now it is full-fledged. Now we have a whole lot of thermobaric warheads, rocket artillery, barrage fires. Why we are talking about this? Because we know then what we can expect of our victims when they come to us. White phosphorus has been used, Ukraine and otherwise they have talked about it. And then they are talking about double tack attacks, which terrorists have also been using. That is when one attack comes and people go to rescue those people, the second attack comes there itself, where even the medicos and the healthcare providers are also targeted. So in Russia, Ukraine, from the Ukraine side, we're getting a lot of information, hardly any from Russia, which is but obvious. There's a kill zone which is present there. It is a 750-mile front line over there. There's a cross asymmetrical warfare with drones being used. The brigade is known as Magyar's birds, and all known doctrines of war, which till now we knew has been thrown asunder after this war. Dug in infrastructures with about 2 to 3 soldiers only hiding over there. Tanks are hidden, everything has gone down. And if I may say so, it's not, I'm not taking out any, state secret. We are now in India also trying to do the dug in as much as possible around the western border. Hospitals in Ukraine are all underground. I'll be showing you pictures. Camouflage and concealment now is paramount. The massive casualties you have, they have said now 2 million soldiers have been killed. Now we are talking about 1,300 something in our, in Kargil about 500 and something. 2 million soldiers here in this place. Now, in Ukraine, they have constructed underground medical stabilizing points. They call them stabilizing points, and hardened bunkers which are present near the front line. Now, these bunkers are completely autonomous. They feature OTs and ICUs. They have independent power supplies, sewage systems, everything. We are taking cues from here around our borders. They can stabilize and treat up to 200 patients, and this is roughly around 6 to 10 meters beneath the surface. Now, this is India, coming on to India. Now, as you can see the map of our country, now on the northern part, we have high hills and snow. This side, we have deserts. On the eastern front, we have jungles. And on both the sides, we have seas. And then we have attacks which can take place on any end, not to mention the terror attacks, civilian terror attacks, which are targeting even in the cities. Now, this is a very unique scenario in India. It is called VUCA, volatile, uncertain, complex, ambiguous environment. Now, currently it is moving from a threat-based counter-initiative. You see the threat and then you go and give the counter-initiative operation towards a capacity-based operation, which is there, no territorial loss. We are very clear, India will not lose any land. And 2 lines are there on both the fronts. Both sides, we have 2 fronts opened up, eastern and western. I think we all know that. One of them is primary with major deployment, and secondary with just deterrent posturing that they should not advance in. Now, coming on to the main thing, where is the role of the medicos in this? Now, the armed forces are, treated by and managed by the armed forces medical services. Now, the basic aim of training here is to maintain a high degree of preparedness in war at all times, continuous, versatile, realistic, taking into account all the peculiarities of environment and the orientation. Both our major enemy nations change their doctrine of war, and we have to be ready for that. Also, resources which are present with us and the limitations should be known even to the doctors. Unfortunately, the doctors, the medical officers in the Armed Forces Medical Services, they are commissioned from diverse institutions with varying degree of training. There's a limited or perhaps non-existent training in combat or even urban trauma at the undergraduate level, as per the latest NMC curriculum. Small hospitals are doing it, short courses, they're doing it here and there, but nothing is standardized and certified. It was in 2013-14, there was a journal of the Armed Forces Medical Services. In fact, four of us, we took out this article that it is time to have our own trauma course, something like which should be custom made for the Indian Armed Forces. This will help to bolster the institutional memory and avoid repetition of the same mistakes. This was the felt need of the hour at that particular time. Now, we have gradually over there, we have something called the Bachav Protocol, which we have, which is present in the armed forces. Yodha Rakshak Bachav Program, we are using the Hindi words here. Treat life-threatening injuries first, BACH. If you will see this, it is basically, the same principles as ATLS and other, TCCC, but we have had our Indian version of it. After the life-threatening injuries are taken, then it is AAV, that means analgesia, antibiotics, akrit, karyava, that is wound dressing, and atrik means something else, others which you have to do, and documentation. V is the Hindi word, it is for documentation. Now, I'll be talking about the principles of TCCC and Bachav with these two pictures over there to show. Now, when we're talking about TCC, there are three divisions we talk about: care under fire, tactical care, field care, and evacuation. We have to move the patients behind, ones who are slightly stable, so that there is no clogging of this line. We have to treat the casualties, prevent additional casualties, and complete the mission. That is also important. Now, on this side are your TCC pictures, and on this side are what happened, the pictures I have taken from what happened in Op Maitri. Maitri was when India was called and was the first responder for the earthquake in Nepal, which took place about 5 years ago. We were the first ones who reached over there. And let me tell you one thing, we carried with us a lot of portable stuff, including first time we deployed the oxygen generating system. They were para-dropped because there was no airfield at that time. They were para-dropped, and within 4 hours, the whole system was ready and we were able to fill up oxygen cylinders which we required. Nitrous again, like the Falkland Wars, where nitrous is the first victim during wars because of the sheer weight and the space it occupies. It cannot reach the forward. And other countries asked us, we did grant them permission to fill up their cylinders from our oxygen system there. TCCC, they are talking in terms of March, massive bleeding, airway, respiration, circulation, and hypothermia. On the Bachav acronym, it is the same thing, almost the same thing. This is limited to care under fire. What can be carried by the frontline medic, not the medicos, and the soldiers who are also trained. We have something in our country called Yodha Rakshak Bachav Kit. It is what was earlier known as the BFNA, or Battlefield Nursing Assistant Kit. Now, as you can make out from here, which I've shared, you have practically everything there, and it is a small compact thing which can be easily carried. Remember, this soldier is not only carrying this, he's carrying ammunition, guns, water, and other things also. Massive bleeding, we'll keep talking about that. Direct pressure before intervention. Now we talk about tourniquets, the hemostatic agents, and pressure dressings. Now, main cause of death is hemorrhagic shock. And this is usually due to the prolonged evacuation time. 53 minutes is taken as an average. In most settings, 60 to 153 minutes. But this can be changed because of ongoing enemy action, which goes both ways, even in civil. I would like all of you to think about what happened in Mumbai in 2008. The Taj Hotel and other things and all that. Ongoing enemy action taking on the terrain, whether that those two were okay that time, availability of transport by air or road, or whether it is day or night. Now, this affects the evacuation time of the casualties. Global war on terror, ever since that has come in, they have started talking about stop the bleeding out in the field. First time they said was possibility of rapid medic evacuation, and we have a whole lot of pictures which are available. You can get them from Google also, of helicopters evacuating patients from the front line. This and the removal of the tourniquet can be performed only by a qualified surgical or emergency medical personnel in a closed clinical environment, so that potential complications like reperfusion injury and renewed hemorrhage does not take place. Now, what was advised, this is our Bachav thing, can be applied within 1 minute, should be applied within 1 minute, 2 to 3 inches above the injury. In case the bleeding does not stop, apply another one on top. And these are demonstrative pictures taken from the manual which comes along with the Bachav protocol. And you write down and there's got a pen also incidentally with it, where you can write the date and time when you started the tourniquet. Like I said, we learned from wars. Ukraine, we have learned one thing, because the information which is coming on, because of the surveillance and attack drones which are there, the timely casualty evacuation is almost impossible now. So other ways of controlling bleeding has to be there, which comes, and to avoid any damage, which comes with leaving the tourniquets too long for that. Now, the tourniquets in Ukraine have told reporters, wherever it is, that prolonged use has turned injury would have been easy fix into organ dysfunction or limb loss. Can you imagine the tourniquet being there for more than the requisite time? So then comes your local topical hemostatic agents. Quick clot, I think all of us know it. Hemclon, another very popular one. And then kaolin based, you have a whole lot of things, semectite granules, woundstat, hemafiber, all of them are there. And along with that, non-woven medical gauze and woven ones, which are impregnated with kaolin and chitosan. TCCC 2026, May 1st, it has come out with. They have talked about the casualties to use the homeostatic agents with gunshot wounds, higher severity, injury severity scores, traumatic amputations, and with tourniquet application, please use the homeostatic agents, because you don't know when you can bring the patient out. Now, in both these guidelines, Hemcon and Quick Clot have been recommended to be carried with or by all combatants. It is buddy system, like even a fellow combatant can apply it on his buddy. This in our Bachav clot, we have quick Bachav packet, we have Quick Clot. It is sealed open. All the soldiers and the battlefield nursing assistants are taught how to use it. In-depth hemostatic agents are also being used for truncal and pelvic bleeding, though it is less, but it is not zero. These truncal and pelvic injuries which are taking place. Extract is there. It is a syringe in which you just pressure it, and mini cellulose sponges fill the syringe, and they rapidly expand and help to control bleeding in a cavity. But again, but comes in. Various studies like Iraq and Afghanistan have shown that only 0.9% of the patients had documented hemostatic use. They were present with the buddies and the medics or the scene, but they did not. And they found no significant difference in those 0.9% of the cases, no difference in the hemostasis and the volume of blood loss between two. Now, what we have also seen, it is an exothermic reaction. It pains a lot when they are putting these local topical hemostatic agents. This pains, and next time when you have to do it, when you do debridement again, you have to actually scrape this off also. So there's more bleeding and poor healing which takes place. TCC guide recommendations in 2026 have said combat gauze to be used, and alternatives they have also given, including IT clamp. Now, what are these IT clamps? I'll just be talking about this. Now, junctional and truncal, which are not compressible or controllable in the hospital scenarios, various devices are there. Pelvic binders, you have the innovative trauma clamp, that is the IT clamp, and whole lot of junctional tourniquets, which are there. Now, this is right on top over here is the innovative trauma clamp, which can be used. It just clamps and puts, you can clamp the artery over there. This. Then you have croc, combat ready clamp. You have junctional tourniquets, which can be used. At times, we have also used pelvic binders, which are thick and helps to prevent the bleeding, especially from pelvis and otherwise. Now, coming back to the rest, this is the circulation part, the bleeding part. Now, airway management, altered mental status. It is as per every ATLS or local trauma courses which we conduct. Gravity positioning we advise, especially it is on the face. Jaw lift, head thrust maneuver, keeping the cervical injury in mind. Nasopharyngeal airway is stressed upon. It is with our Bachav, the Jodha Rakshak kit, and surgical cricothyroidectomy has also been taught in the by the doctors who are in the periphery, in the front. These are the airway devices which are used. Now, for respiration, we are mainly worried about there should not be any chest pneumothorax. So, decrease or open wound of the chest. Decreased breath sounds, blue color, we have to look for that. Remember one thing, we do not have SpO2 probes over there. For the traumatic chest wall defects, occlusive dressing, the Asherman chest seal by the TCC, we have got the Thulok chest seal, which almost works in as you can see over here, almost works in a similar way. And like I said before, all our soldiers are trained for it. IV access for circulation, that should be gained immediately. Single 18 gauge catheter. IV is not started distal, obviously, to a wound. It is pathological. If unable, then IO line should be started intraosseous. Now, CVP line. Can it be tried without a ultrasound? Because remember one thing, in the peripheral, in the forward areas, ultrasound is not available. And a comparative analysis was done in 23. It was published about the ultrasound comparative between external jugular or an internal jugular just by landmark techniques, and they found it was 78 and 88% over there. The success rate for the internal jugular was 88, while the external jugular was only 78%. So do give it a try, the internal jugular veins, if one is not there. But there's certain wounds like this, which really you can't compress much. Then comes the military application of tranexamic acid. Matters study was there. There were two others studies which was conducted before. And this was a level 3, role 3 echelon hospital in southern Afghanistan by the NATO forces. Now they did that and found the mortality was definitely, use of this definitely improves the mortality figures. Then pain management. I had gone to in the rescue operation in the Bhuj earthquake, and I realized that when we were extricating the patients out from all the slabs and everything which were there with crushed injuries, the biggest problem was pain. And how do we take it out? And very frankly, over there, I learned how to do by, the caudal technique as to inject lignocaine. That was what was available to me for extrication of patients. Non-opioid analgesics, I would love to have it, especially in battlefield areas. Opioid analgesics, either you have fentanyl or morphine. Now, this is what is seen over here. This is something called tubomorphin, which was given, sir would remember this. Moment the medical stores used to issue it, we knew war was imminent. And this was injected and given over there. However, now at present in this scenario, fentanyl may or may not be available usually, but nalbuphine is what we feel is the drug to be used. It does not come under the Narcotic Drugs and Psychotropic Substance Act. Well, actually, that is not to be said first, but it is got a better safety profile and only mild side effects. like sweating and headache and all that, but does not get the what we are always worried about is if suppose you do too many, give too many drugs, so they may be a CNS depressant. Now, TCC rules have talked about if the casualty is fight or mission capable, then analgesia is self-administered. They normally are carrying in their pouch, they carry a combat wound medication pouch or a pack which contains acetaminophen, meloxicam, and a new drug which now has been introduced is suzetrigine. It is a drug they have now introduced. It is one of its kind and oral drug which is non-opioid. If the casualty cannot fight or is non-mission capable, then take directly, ask them to take the same pack, and the TCC medical people can give ketamine or transmucosal fentanyl citrate. Now that is usually taped on the finger and told to put in the cheek, and they can keep taking licks from there. Endpoint is obviously reduction of pain on the nystagmus. Now coming on to the H part, hypothermia or head injury, obviously restrict movements who have or are suspected of having spinal injury. The TCC guidelines in this has changed a little bit. They have focused now on seeing the war scenarios going on everywhere, continuous reassessment and physiology guided care. They standardized a time-based algorithm to minimize any ischemic complications from evacuation because of due to tourniquets. Conversion beyond 2 hours, they have said it is restricted to medical personnel, but it can be done as forward as possible if the conditions so are there. They have changed the antibiotics which are there with in the packs for the soldiers, and the targets which they have labeled for TBI, which can happen, is they have maintained that. They have changed that slightly. And most important, any penetrating traumatic brain injury are no longer automatically classified as expectant. Expectant means no treatment to be given. You expect them and give them just, end of life care type. So that is not no longer recommended. So this is our, you saw the hospital of Dr. Neha. This is the hospital, how we set it up in Op Maitri. That is the earthquake in this place and in Nepal. And principles of tactical care, as you can see, these are wards, and this is what is set up within 4 to 6 hours. Stress on damage control resuscitation, not one technique, but it is a group of strategies that address this lethal triad: coagulopathy, acidosis, hypothermia. And we talk about the lethal diamond when there is severe blood loss. These are standard ATLS. Also, we talk about this: hypocalcemia, acidosis, hypothermia, and coagulopathy. Now, principles of combat anesthesia. That is, now we are coming back to the field hospital where anesthesia actually comes in as we know it. It is as per the changing role of combat anesthetist. Resuscitation, smooth transition of care to the OT, and to assist in invasive procedures. We start there. That means we also facilitate the damage control surgery. Now, preparation moment, we get a trauma patient, you start receiving information. Moment you start receiving information, activation of operation theaters and screening of blood donors. Quick reassessment has to be taken there as per ATLS guidelines. Circulation, assessment of circulation as per the physiology of the patient, the anatomy of the injury pattern, the mechanism of injury, and his response to the initial resuscitation. Here at this level, we are talking about EFAST also. We have them at the forward locations. And bleeding is to be stopped as close as possible. Rescue foam and even RIO, which resuscitative endovascular balloon occlusion of the aorta. Combat casualties should be wheeled in without waiting for investigations. Maximum you require is serum lactate and base deficit to talk about your the adequacy of resuscitation. If there is a need for blood transfusion, which usually is, so you do the hemoglobin and grouping and cross matching. DCR is preferred over damage control resuscitation, over aggressive resuscitation. Target BP 100, not more. Unless, of course, there's TBI. When you do that, it goes up to 110. That is the systolic blood pressure. And tranexamic acid is again the same. And HES is no longer used as a resuscitative fluid. And even the recombinant factor 7 is no longer recommended. Massive blood protocols are to be initiated immediately. This is at the field hospital if meeting the updated risk criteria. So various scores are there which you can give. Now, great emphasis on the use of low titer O whole blood. Fresh whole blood, you have walking blood banks, which was stressed in Afghanistan. And frozen RBCs and frozen plasma has been given. These are the blood boxes which are present in the Indian Army. They're active. They have got a battery cooling. So you can, active means they've got batteries inside and battery operated. 30 bags can be given. This is passive, in which you have ice kept below, and then it can take about 20 to 30, and another one for about 8 to 16 blood bags which are taken. These are immediately airlifted from the base or the third echelon to the forward, fourth echelon to the forward third or second echelon. Hypothermia, like I said, to be prevented, warm the OT, warmed IV lines. Now, you can imagine in Kargil, it was a big problem at that particular time to warm the OT, but generators and the rest of the army, the other part of the army, they came forward and they helped us to keep the OTs warm. Nowadays, we have forced air warmers, rapid infuser, and use warm washing fluid. Analgesics and antibiotics to be given at the time of arrival, and expect always in any trauma case to be prepared for a difficult airway. So RSI is recommended. Now, anesthesia over there is good monitoring equipment, very important. Those days are gone when we had either pink or blue patients without the SpO2. We require good monitoring equipment. We provide an anesthetic that minimizes the hemodynamic stability during damage control surgery. So induction of anesthesia at this particular time is can be disastrous and to be handled very carefully. The standard medications are not as effective as required because the machines also are electricity driven. And then, like I said, non-nitrous anesthesia machines have to be used. If possible, it is there. VIMA and TIVA are the mainstay, and we should get ourselves experts in that. Use General Montgomery said, those who sweat more in peace bleed less in war. So we should practice both these in our day-to-day activities, day-to-day OTs. Combat anesthesia, obviously, benzodiazepines are grossly restricted. In fact, we don't advise them at all because we are concentrating on ketamine and opioids, like we said. Ondansetron has got quite a big role. It is given routinely. Normotension should be targeted. Only one surgical hemostasis is achieved, and extubation can be deferred. We are not in a hurry to take out the patients in these peripheral hospitals. And if suppose it happens, then lung protective ventilatory strategies, as is for your ARDS and otherwise, it has to be adopted over here. Regional blocks, that is one of the best which one can do. So portable ultrasound has been now given to the US Army and now even to our Army in the periphery. It is going quite close so that we can start using them. These are small ones which can be used for giving nerve blocks. Now, two slides on additional consideration. If suppose the ward is at high altitude, you went to Kashmir, Dr. Neha, it was not high altitude, but high altitude, we're talking about 15,000 feet or 8,000 feet above that and 5,000. So extra oxygen routinely has to be given, an FiO2 0.3 at 5,000 feet and FiO2 of 0.4 above 10,000 feet. The hemorrhage increases over here, maybe because of the polycythemia and the coagulation disturbances which are there. Spinal, if one attempts, even in a fixed hospital over there, like in MH Kargil, the incidence of PDPH is very high. Maybe it is because of hydration or because of hypoxia. Drugs, obviously, to be used carefully. Equipment check. anesthesia machines and vaporizers should be checked and given. Now, the biggest problem which comes, which sometimes some questions are also asked, what about the vaporizers in these high altitudes? You have two types of vaporizers, variable bypass, and you have your multiple, you have the other one, like desflurane. Now, in the variable bypass vaporizer, you have two things we talk about. We talk about the output of the gas and we talk about the partial pressure. Now, in the output, total volume of the gas output becomes higher with the variable, while the partial pressure is less because of the high altitude. So the volume of the output, the same which is there, becomes higher and the partial pressure becomes lower. So almost it is same. So in the variable bypass vaporizers, what you dial in altitude is what you're going to get at sea level. Now, coming on to the measured flow vaporizers. The desflurane chamber is sealed unit at 39 degrees. Then you have an injector and everything. This is not exposed to the atmosphere. So we have to compensate for the altitude. Now, the same volume percentage of the output gas, but the less partial pressure, because that is as per the the pressure outside because of high altitude. So here we may need to change the dial settings to maintain the same partial pressure. And remember one thing, partial pressure is what causes the effect. So a measured flow vaporizer is really not what is required in high altitude. Then coming on to tactical evacuation care. How do you take the patients back? Because the role of the medico is there also. This is a globe master, where as you can see how well it has been made for patients to be taken. Otherwise, we have road transport and helicopters, which we are using. This is the Cobra Gold, which I attended. It was senior command and leaders, in which that time 7 and now 12. And now we have almost 33 neighboring countries attend that, so that in case there's a trauma, which is across borders, we are able to communicate with each other. Now, casualty evacuation during Operation Enduring Freedom, Iraqi Freedom, and New Dawn. They almost went, jumped into each other. US echelons talk about 1, 2, 3, 4, and 5, while NATO talks only about role 1, role 2, role 3, where is theater hospitalization. Role 4 is continued care outside the combat zone. Now, to give you an idea about this, now here you can see this. This was Afghanistan. From here, you have role 1 and role 2 was here. 3 was in the naval hospital ship here. And here it was there. This another area in, they went to Israel. They went here, Turkey. And then here comes in Germany and Spain, where there was the role 4 hospitals. All the brain dead people, incidentally, were bought here. Organ donation was very high in Germany and in Spain during the time of Afghanistan war. And from here, 5 was trans-Atlantic. It went over to the military hospital, especially the Walter Reed Hospital. So the whole globe was covered in the casualty evacuation. Now, Roaring Iron and Epic Fury, which is currently going on. From Iran, they are going to Jordan, and not to Syria, of course, Jordan or Israel. And here, of course, they go to Kuwait. These are the 2 areas. Now, here went from echelon 1 to 2, the Black Hawk, helicopters and CH-53 helicopters. Then after that, you have C-130, and which are there from 2 to 3. They are fixed wing, unpressurized. And here from 3 to 4 is the Globe Master. India also has these. I've just shown you the picture of that. They act as flying ICUs, and they are high capacity aircrafts. Now, what are the peculiar problems here which are being faced in Iran and US fight? That is Operation Roaring Iron Lion and Epic Fury. They did the contested airspace. Iran has got sophisticated weapons which are making standard air corridors very dangerous. So it is difficult to know when are you going to take the patients out. One-way attack drones, long-range surface-to-air missiles. Then the golden hour is getting strained. Greater reliance on echelon 2, the forward teams, as compared to what was there in echelon 3, what was there in Afghanistan. Host nation sensitivities, they have to cross Soviet borders, Iraq to Jordan, Kuwait, other areas, and the political alignments are changing. We've been seeing the news. Rapid diplomatic overflight clearance is required, and international coordination is there. Shortage in this war, they have seen of nitrile, which is a petroleum-derived product, and helium, which has been used for MRI and for other procedures. Ukraine, I found it very interesting. Role 5, you have role 1 is point of care. It is immediate self-aid buddy, like we said, in our soldiers are doing that. And uncrewed robotic drones are being used over here. Role 2 is what they call as the stabilizing points. They are the casualty collection points. Advanced hospitals, like you can see over here, this is the role 2, where you have equipped with OTs and resuscitation stations. Then role 3 are the regional hospitals, closer to the urban centers. Role 4, national, central hubs like LEAVE are there. And internationally, they're going across 30 partner countries, 33 as of yesterday, under coordinated European mechanism to move the patients outside, and rapid use of these road transports. I just wanted to talk in the end, just 2 lines I should slide about the type of documentation which was done in by the US Army. US Armed Forces Health Longitudinal Technology Application. Now they unite almost 485 US military posts. Now this electronic health record has been implemented very long, and it has supplemented into the composite healthcare system. It is linked with the Joint Theatre Trauma Registry since 2004, and even retrospective, they have added their things inside. This is the type of tablets which are there at all levels. In the forward area, initially they used to have small pen drives type of thing which can go and fit into all these, and subsequent, once the network is available, you don't require any pen drives. Now this is it. You just use it with a pencil and carry on putting tick marking whatever is the point there. Store and forward mode, it is real-time mode which is being used. And this, you can see, is how detailed is the presentation. It is so much, all these records. Then now after that, when they talk about the treatment, how are they demographic, the problems, the allergy, everything is given over there. Now after this, when they analyze it, they're able to come out with various protocols and policies, like we have seen this already happening. It is paperless, rapid, coding is there, done at site, and online access to all military health system beneficiaries, and there's a central storage of the standard data, which is shared worldwide between clinicians, the veterans, and the Department of Defense. So you can imagine the type of data which is available on war injuries, especially with the US, and shared with NATO. Thank you very much.
Thank you, ma'am, for a lovely talk. You gave us in the initial part the global scenario of preparedness and the activities that are done all across the world. And you ended up also with the same global scenario. And in between, you had exhaustively discussed what the Indian scenario was. And I'm sure this must have been a feast and some new awakening amongst our friends who are on the listening mode today. Because it's not every day that you hear such great talk from very important personalities in the armed forces as soldiers. So thank you very much. And Uma madam,
Yeah.
If there are questions, yes, you can.
Yes, are there any questions? I haven't seen any in chat box. And it was like a dream, madam, to us to hear about it all. And I felt very nice that the technological advances have reached our soldiers and you have been provided those things. Because I had read a book by Dr. Norman Bethune, who worked in the First World War, and how he hung bottles of blood to the trees to give it. So it was very nice to hear all those things are available to you. I don't think, are there any questions in the chat box? I can't see them. Garcha sir, you wanted to talk about your experience.
If there is time, I can take
Yes,
5
sir.
minutes.
Yes, sir. Yes,
Sir,
sir.
before I end, I just like to add one thing. Why
Yes,
I
ma'am.
added all this is because I wanted to let our fellow anesthetists know that we are also achieving quite a bit. Our medical care in the forward areas at the
Yes.
time of war and peace is quite good, almost at par with the rest of the world.
Global
So it
standards.
gives
Yes,
a very reassuring feeling to us.
absolutely.
So with that.
It makes us proud, ma'am. This talk has opened our eyes, and we get to know so many things which have happened of late, and how our armed forces has progressed as far as the medical care and safety of patient is concerned.
It's
Excellent
really
talk.
nice to hear that, madam.
Thank you. Thank you,
And,
sir. Thank you.
Yeah.
Just
ma'am.
wanted to say something about, can you, sir? Can you add, sir?
Yeah, just a short this thing. I've served in 2 sectors during my tenure of 29 years, 30 years in service. One was the Indo-Pak War of 1971, when I had just not finished my internship. Also, we were posted there as MOs. So there, actually, in these forward areas, at that point of time, and it still continues in a similar manner, we have the RAP, that is the Regimental Aid Post, and 1000 का एक approximately battalion होता है, 1000 people, in which there are 20 officers and about 30 JCOs and ORs, and over that 1000 there's one doctor. So that way the RAP is manned by one doctor with 6 to 7 nursing assistants, okay, which in peacetime play the band, and during wartime they practice as paramedics. So they do a dual, they're multitasking people. So that is the RAP. So once the war breaks out, it is the first doctor who attends to the person there with shell dressings, those days, shell dressing. And we had, as madam has mentioned, tubonic morphine. That was not tubonic, but it was imported, and it had a small tube, and at the end there was a needle and capped. So you remove the cap, clean the skin with spirit, and push the needle and press the tube, and 15 milligram of morphine used to go in and discarded. And also on the forehead of the patient, when casualties come, they don't come 1 or 2, 3, 4. It comes in 15, 20 ke lot mein aati hai. And I was the first receiving doctor at that point of time. What you call in civil is the casualty medical officer. In the army, we used to call them at that time as DMOs, so duty medical officer, and you assisted by some others. So in that field hospital where I was working, that was a 75 bedded hospital, and surprisingly, both the, as madam mentioned, कि अब हम लोग underground भी बना रहे हैं. Those days, just before the war, 1 month before the war, that was 3rd of December 71, we had gone underground as far as the OT is concerned, and also 25 medical ward beds and 25 surgical beds. So 50 beds were underground, and the operation theater, which was in a U form. In the first, as you enter the theater underground, the first thing is the reception, where the patients are received, and pre-op area. Then comes the X-ray unit, and then proceed first OT number 2, and CSSD recovery, and out to the wards. So it's in a U-shaped manner. This OT was dug. So even if the bomb drops just a foot away from the operation theater, nothing will happen inside. And similarly, it was for the wards also. So that was the layout. So we had gone, and this entire OT was made in 12 hours, underground digging and establishing in 12 hours. We could do that. This was somewhere around October 23rd, 24th of 1971. 3rd of December, the war broke out. When the war broke out, I was duty medical officer that day. And it was around 5:30 that the Pakistanis came in Air Force full, about 10-15 aircrafts, and huge sound came up of blasts just next to our operation theater area. I mean, the field hospital area. So my commanding officer, who had about 20 years of service, he asked me in Punjabi that Kaka ki hoya? I mean, what has happened? So are you okay? I said, I'm absolutely fine. He says, where has the bomb fallen? So I said, between the surgical and the medical ward. That is my estimate. So he says, I'm coming quick. So he rushed and he came, and we saw. And then later on, I realized, because that was my immaturity at that point of time, the bomb had fallen 1 kilometer away from my hospital. But the blast sound and the lighting was so much that I thought it was just between those areas. So that is how it was, on, and with the pencil, we used to mark morphine 15 and time we used to put on the forehead of the patient. And those were the patients, as madam said, कि वो जो retrieve नहीं कर सकते, उन patients को हम लोग ये ऐसे करके segregate करते, priority किया 1, 2, 3, and that day. So those were the early days, but we have progressed quite. And also inside the theater, I want to tell you one more thing. You open up one pack, there'll be sterile clothing for 5 people, including the nurse, the assistant, the surgeon, one assistant. So 5 dresses nikalti along with the cap and mask. So you could use compact, we used to call them, I'm forgetting the name, compact OT dresses. So you open up that and 5 dresses usme se nikalti thi. So that's how the things were those days. And Kargil, of course, was during peacetime. And we had a lot of mine injuries those days. We used to travel from one place to another. And the mines which were laid down by Pakistan right from Independence Day 47 onwards. So 71, nobody knew left par hai, right par hai, kahan hai, ye hai, wo hai. And there are certain virgin areas where we had never gone. So galti se bhi udhar gaye to blast ho jata tha pair mein. And I saw a lot of foot injuries and mine injuries during my tenure in 74, 75, 76 when I was in Kargil that time. So immediately after the 71 war, I had a 1.5 years tenure peace mein, and I was again sent back to Kargil at an altitude of 9,500 feet above the mean sea level. And they're wonderful time. But then when these injuries come, I used to be assisting the surgeons and the anesthetists both in the operation theater in Kargil. So those are the days when things were early. But then at that point of time also, we had great medical care organized in the field area. So that's in short about this. So this is a very small talk as far as our 2 pioneers are concerned of today, who gave us an excellent talk on Madam Neha has given it on peacetime mein jo hua, and Madam Rashmi Datta has given peace as well as war. So thank you very much both, and thank you, Madam, for giving me this chance to chair the session.
Thank you very much, sir, for sharing. And actually, all this is very overwhelming. And I mean, our thought process is at such a level that we are all speechless. Probably that is why there are no questions in the question box, because there's nothing we can ask. But we really feel happy that in deep in our minds, we feel that anytime you have shortage of people, please call us and we'll be there to serve in any capacity you need us.
Thank you.
So,
That's very,
Madam,
very encouraging. Thank you so much.
Yeah.
Yes.
And Dr. Maya, I think, has given a comment, a question about how do we keep our mental health during
Yes.
this time. That is what we have all been trained at as a doctor and as anesthetist. We have to take over. We have to take over the leadership over there. We make sure everybody gets their sleep and food. The mental health and work is there. So mental health is taken care of.
Yes, yes. That is very, very important, because working in such conditions, it is sometimes tiring, as well as you get fatigue because you're working tirelessly from morning to evening, and the situations are sometimes very emotional, and sometimes we may feel that we are low in our moral, and things are not like as we think.
And
So
talking to people, you know, if suppose
yeah,
we lose somebody, and we see very bad cases when they
yeah,
come, you know, gunshot wounds and mind blasts, like Sarah said, they're sometimes very bad.
absolutely.
And when we feel low, obviously our other people are also there. We talk to each
Yeah.
other. That
So
is
you
very
need to have great leadership in that case,
great
because your
leadership,
team,
great communication, good rest, and
yes,
this thing. So
proper
that,
food,
yes,
nourishment.
Yeah.
Yeah.
Now,
Yeah.
food, that part is looked after.
yeah.
Yes.
So
This endless actually. We could have chatted a lot more about it, but since we have some restriction about times,
yes.
I will request Dr. Chaya to deliver the vote of thanks from SAPC.
Yes,
Our
wonderful, madam.
secretary.
Rashmi madam, Neha and Garcha sir.
Very nice to have
Really
all
a
of you.
highest respect and admiration for you all. What you are doing, we are doing nothing in front of you. Great.
No, 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 not at all.
Not you are as important as
Yeah.
anybody else,
Yes,
ma'am.
yes,
So
yes.
Thank you so much.
Can I
Thank you.
share my experience? I was with Neha in Jammu and
yeah,
Kashmir.
absolutely. Madam
Yes,
Uma,
Hello,
sir.
sir.
Yes, sir.
Yeah, myself, Dr. Sakra, I am a gynec, I am now the anesthetist. But Neha and Manju has given me the link, and I am very having keen interest in listening the all experience, particularly Datta madam's experience and Pasista sir's experience were really a great work they did. But our work does not only benefits the patients. When we did our first camp in Jammu and Kashmir, I think Neha was not there in that. That camp was at Ganderbal and Baramulla, and it was a long back, and we were quite very whether patients will come to get them operated and all the things. But the response of camp was so nice that we were going on operating every day. The list was more than 40, 50 in all the departments. One of my colleague from Surat, Dr. Mahajan, I was an in charge for Ganderbal hospital, and he was saying, sir, मिशन सक्सेसफुल हो रहा है ऐसे लग रहा है क्या? तो मैं उसे बोला कि मुझे अभी नहीं लग रहा है सर, ऐसी कैसी रोज 40-50 सर्जरी हो रही है, आपको कैसे नहीं लग रहा है? एंड वी हैव अ ग्रेट ट्यून विद अदर पीपल्स. रोज बिरयानी लाता था कवा, सब 2-4 बार दिन में वहां के पूरे जो वर्कर्स है कवा चाय इतना घुलमुल के पूरा एनवायरमेंट था. लेकिन फिर भी मेरा मन नहीं मान रहा कि ये मिशन अभी तक सक्सेसफुल नहीं हुआ. और लास्ट बटवन डे को जब लास्ट बटवन डे था तो हम मार्केट में जाने का सोचे, क्योंकि अब घर पे जाना है तो कुछ सोवेनियर्स लेना था घर पे जाने के लिए. तो हम मार्केट में गए, मेरे साथ डॉक्टर महाजन थे, और एक दुकान पे गए, वहाँ कश्मीरी चीज कुछ चीज थी. तो मैंने एक चीज उठाई और वो एक लेडी बेच रही थी वो चीज. तो मैंने पूछा कि कितने को दी? तो बोला सर 150 रुपए में. छोटी सी चीज थी वो, मट्टी की बनी हुई. तो बोला 150 इतना महंगा कैसे, क्या ये तो इतनी महंगी नहीं होनी चाहिए, आप इसको 50 में दे दीजिए. तो वो पहले बोली नहीं, लेकिन अंदर से एक बूढ़ी बूढ़ी औरत आई है वो दुकान पे. अंदर से आई वो दुकान, शी मस्ट बी एन ग्रैंड मदर इन लॉ और ग्रैंड मदर ऑफ दैट लेडी. और उन्होंने कश्मीरी में कुछ बात की. तो एक 5 मिनट उनका कन्वर्सेशन हुआ और फिर वो लेडी आई, ठीक है सर 50 रुपए में लेकर जाओ. तो आई वॉज सरप्राइज कि 150 की चीज 50 में कैसे क्या दे रही है वो, सिर्फ कन्वर्सेशन की वजह से. तो मैंने पूछा, अरे अभी तुम तो अभी नहीं बोल रहे कि कम नहीं होगा, अभी 50 में कैसे क्या दे रही है? नहीं बोली, मेरी सासू माँ बोली कि इतना रिस्क लेके इतने दूर से तुम्हारी ट्रीटमेंट करने के लिए डॉक्टर्स आए हैं, उनसे तू क्यों भाव कर रही है? सो दैट वाज हर एक्सप्लेनेशन. तो मेरे साथ डॉक्टर महाजन थे. मैं बोला, डॉक्टर महाजन मिशन सक्सेसफुल, अभी लग रहा है कि मिशन सक्सेसफुल. So he was so happy. It doesn't change the minds, it can change the minds of local people also. So that is the real success of such missions, such activities which we people carry on. And we must be proud for ourselves also that what work we are doing for the nation. That is the gimmick of such missions.
Yes.
I congratulate Dr. Neha for doing a wonderful job in our second Jammu and Kashmir mission. So thank you for giving
Thank you so
opportunity
much,
to
sir. Thank you so much.
Dr. Chaya, you could continue.
Yes, yes. Thank you, madam. On behalf of SFPC, I would like to thank SAM's president, Dr. Avinash Bhosle sir, and also honorary secretary, Dr. Sheetal Dalal madam, for giving us the SAM's platform for webinar. I thanks our own sir, mentor, our guru, Dr. Garcha sir, for chairing a session so wonderfully and also sharing his own field experience. And sir, happy Guru Purnima to you.
Thank you.
I'm
Lots
very
of good wishes.
Yes, sir. Thank you so much. I'm very proud to thank our own student, my own student, Dr. Neha, for a very successfully conducting a anesthesia camp in Kashmir in spite of lots of challenges. As a civilian, we are not aware of medical care advancement and progress of our own army during wars, massive casualties, and also during earthquake and anesthesia resuscitation conduct. So Major General Dr. Rashmi Datta madam has explained it so very well in her talk. I thanks madam for such a wonderful informative talk on anesthesia in armed conflicts. Thank you, ma'am. I also thanks our own president, Dr. Uma madam, for moderating a session very nicely. I thanks all the members who joined for the webinar. Last but not the least, I thanks our Mr. Ganesh from Zeneca for flawless IT support. And thank you everyone for joining the webinar, and have a good day and good night.
Dr. Chaya, one request. Dr. Shilpa want to ask something. She has raised her hand.
No,
So she can talk then.
no, ma'am. If you give a few seconds, is it okay after vote of thanks? Sorry.
Yes. Okay. What you
course,
can talk if you have any question or anything.
No. It's a really great session by Dr. Neha and great teamwork by Manjusha Bhume. She was also leading anesthetist. And of course, hats off to Dr. Garcha sir. Dr. Garcha sir, I'm Dr. Shilpa Guru, minor
Yes, ma'am.
HOD.
How are you?
And
Good
very
evening.
nice to hear you. And hats off to you for dedication. And great, no words to. My question is to Dr. Rashmi Datta. Can I ask, ma'am, please? Hello.
Please. Yeah, I'm there.
Yes, ma'am. Ma'am, correct me if I'm wrong. I want to ask you, in a civilian tertiary care hospital, which, one or two TCC principles do you feel can be most effectively incorporated into routine trauma management? Means for the improvement to improve the outcome. I want to take tips from you. Sorry, after vote of thanks, I am disturbing you.
I am at present working in a trauma center,
Yes,
and I'm
ma'am.
looking after the emergency there. And we get a lot of road traffic accidents and everything. We are going as per the ATLS principles over there. The ABCD is done initially. After that, we disrobe the patient, examine exposure, examine the patient. These ATLS principles. And what I've always been talking to Dr. Chakra Rao also, that we have got ACLS and BLS our own now. We should also now get similar ATLS principles, but the same ATLS principles in civilian hospitals, it should be managed over there. The same way it should be there.
Okay, ma'am. Okay. Thank you so much. Thank you. And salute to you both. Army anesthetists are really, we are nowhere in front of you.
No, not at
No,
all.
ma'am, no.
Don't say that. Please don't say that.
Okay. Thank you so much.
Thank you.
Thank you, Dr. Shilpa. Yeah.
Thank you, ma'am.
Thank you, everyone.
Yeah.
Thank you, ma'am.
Good night, and let's end this.
Yeah, thank you for giving me this opportunity to speak over here. It was a real pleasure to interact with all of you. Thank you really very much. And
We were honored to have you, madam.
No, it
Thank
was
Yes,
nice.
yes,
And
yes.
if I may be allowed to leave the session,
Yes,
good
yes.
night and
Good
thank you
night.
once again. Thank
Good
you.
Good
night.
night, everybody.
Good night. Good
Good
night.
night. Good night.